Good evening. I'll be speaking on perioperative uses of anti-VEGF in surgical cases, and the session will be moderated by GSR sir. Yes. This is the overview of my presentation, where I'll be speaking about the use of anti-VEGF. Why do we need to inject them? What is the ideal time to inject? Precautions to be taken, and when should be used with caution? And what are the situations when it is better to avoid? And which is the best injection? Now, any vascular injury can create an imbalance between angiogenic factors, which creates an environment of pro-angiogenesis and allows new vessels to extend on the retinal surface and also on the choroidal surface. Also, they can cause fibrous tissue proliferation. The main aim of anti-VEGF is to bind to the VEGF receptors directly or can bind to the VEGF and inhibit its further binding to the receptors. These are some of the common perioperative indications. It can be used preoperatively in cases of proliferative retinopathies. Among proliferative retinopathies, the most common indication is complicated PDR. It can also be used in case of diabetic macular edema, in cases of neovascular glaucoma, in cases of recurrent vitreous hemorrhages after vitrectomy. Intraoperative indications can be like in cases with PCV related bleeds, and in cases of proliferative diabetic retinopathy, some surgeons prefer to inject at the conclusion of surgery. These are some of the common indications for diabetic vitrectomy, like in cases of non-resolving vitreous hemorrhage or in cases of recurrent vitreous hemorrhage. It can also be used. Diabetic vitrectomy is an indication in cases of a tractional retinal detachment with or without rhegmatogenous detachment, and in cases of vitreomacular diseases like vitreomacular traction, retinal membrane, and recalcitrant diabetic macular edema. But all cases doesn't require anti-VEGF. Those who benefit are cases with extensive fibrovascular proliferation, young diabetic with flat vascular prolif where there is no plane for dissection, and in cases of rubeosis. Some of the issues related to diabetic vitrectomies are they have broad areas of proliferations with multiple focal attachment, which makes induction of PVD very difficult, and in doing so can induce iatrogenic tears. Also, they can have combined rhegmatogenous detachment where retina is stiff and small breaks can be hidden under polyps, which can be missed intraoperatively, and later they can present with recurrent retinal detachment. They also have issues of ischemic retina due to poor perfusion of the disc and retina. Added to it, the abnormal vessels which can bleed during surgeries and increases the complexities of the surgeries. Now, how does anti-VEGF help? Why do we need to inject? There has been various studies conducted. They have calculated the VEGF level concentration in vitreous and aqueous and correlated them with intraoperative and postoperative complications. And they have found that reduced concentration of VEGF level results in decreased both intraoperative and postoperative complications. These results support the perioperative uses of injection in reducing the complications. Now, how do they help? They induce regression of the new vessels and also creates a plane for easier fibrovascular membrane dissection, which reduces the complexity of the surgeries, shortens the surgical time, reduces the intraoperative bleeding, also iatrogenic tears, less use of additional surgical tools like silicone oil, and also decreases the reoperation rate and decreases the incidence of postoperative vitreous hemorrhage. Now, which is the best time to inject? Various studies have shown different results regarding the ideal time period to inject. We have already seen the beneficial effect of anti-VEGF, but they also have concern like when there is a gap between the injection and surgery, like after 14 days, they can induce fibrous proliferation. So an ideal time period should be chosen depending on the pros and cons. The first study have shown that ideal time period to inject is within 7 days post-injection, whereas the second study had compared three different time period and they have shown that the best time period to inject is within 6 to 14 days. Now there is something called crunch phenomenon, uh, which is defined as progression of tractional retinal detachment following injection. Those at risk are with duration of diabetes more than 15 years, when the duration of injection and surgery is more than 13 days, and the risk is more in cases when the severity of diabetic retinopathy is more, and in cases of high dose of injection, which is generally not used. This is seen commonly between 1 to 6 weeks. Mean time period is around 13 days. and they can manifest either as a new onset tractional retinal detachment or progression of the existing retinal detachment, or like conversion of a tractional retinal detachment to combined retinal detachment. Why does this phenomenon occurs? Because after injection, there is a steady decline in the VEGF level, whereas the connective tissue growth factor level remains constant, which can accelerate the process of fibrosis and can lead to this crunch phenomenon. Hence, it is important to inject within 3 to 10 days post, it is important to operate within 3 to 10 days post injection. Now, anti-VEGF also have a role to prevent recurrent post-operative vitreous hemorrhage. There are studies which have shown that blockage of VEGF level when administered at the time of surgery is more beneficial rather than giving the drugs preoperatively. So some surgeons still inject at the conclusion of the surgery, but this is controversial. So not only they can prevent post-operative hemorrhage, they can also be used as a treatment option in cases of recurrent post-vitrectomy hemorrhages, which clears the blood faster and regresses the new vessels, both at the retina and also at the sclerotomy sites. There is something called post-operative vitreous cavity hemorrhage, and the incidence is quite high. It is around 20 to 30%, and it can be divided into early and late hemorrhages. Etiology in early hemorrhages can be because of the remnant new vessels or the remnant dissected tissues from clot lysis and leaching of RBCs from the retained old blood hemorrhages. And late hemorrhage can be because of the formation of a new vessels or a vessel growth at the sclerotomy sites. They can result in delay in vision rehabilitation, and the RBCs that are released can cause the trabecular meshwork blockage and lead to glaucoma. The role in anti-VEGF in such scenarios are they can prevent early post-operative vitreous cavity hemorrhage, but their role in late hemorrhages are uncertain. Now, which is the best anti-VEGF? There are very few studies comparing among the perioperative anti-VEGF. This study have seen that when compared between bevacizumab and ranibizumab, they are equally efficacious to prevent intra-op and post-op complications. Another study have compared aflibercept with bevacizumab, and here aflibercept scored better in terms of shorter surgical time, less need for additional surgical tools, and better post-operative vision outcome. Now, what are the situations where we should use anti-VEGF with cautions? Like when the fibrous proliferation or the fibrous component is more than the vascular component, when there is tractional retinal detachment threatening the macula. Systemic causes can be like recent history of stroke or myocardial infarctions, and in cases where we anticipate that there might be delay in systemic clearance, it is better to avoid injection in such scenarios. Moving on to the other indications, diabetic macular edema when planned for cataract surgeries. Pre-existing diabetic macular edema is a major contributor to post-cataract surgery vision loss. Also, post-operative inflammation can exacerbate this DME. So it is important to treat them before surgery. Now, there can be two case scenarios when we have an adequate fundus view and DME can be assessed clinically and with OCT. So, before surgery, it is important to treat them. When this is not possible, surgery can be done along with injection, or we can inject 2 weeks post op. PCV related bleed can present in multiple scenario, can multiple ways. They can like a known case of PCV can present with vitreous hemorrhage, and not because not the vitreous hemorrhage is not caused due to anti-VEGF injection. In such cases, they can be taken up for vitrectomy along with anti-VEGF. Another case scenario can be like a patient who is not a known case of PCV presenting with vitreous hemorrhage, but the ultrasound features suggestive of PCV related bleed. Such cases can be managed either with combined vitrectomy or anti-VEGF, or at the end of the surgery, they can be evaluated further and then treatment can be planned. In neovascular glaucoma, the main treatment is pan-retinal photocoagulation followed by filtration surgery. But in some scenarios, when PRP is not possible because of abundance of new vessels or because filtration surgery has failed, In such scenarios, we can inject anti-VEGF, which improves the surgical outcome of the filtration surgery and also reduces the new vessels. And this reduction of new vessels in the angle have can cause lowering of IOP for a short period of time. Rarely, anti-VEGF can also be used in retinopathy of prematurity, like in cases of stage 4 ROP with extensive neovascular proliferation. It induces regression of the vascular proliferation and they have better outcome when combined with vitrectomy. Other indications are like in other proliferative retinopathies like sickle cell retinopathies in predominantly in African population, vasculitis both inflammatory or infective in case of FEVR, in case of retinal vein occlusions, vitreous hemorrhages following VHL or optic disc angioma. Moving on to our case scenarios. This is an elderly male not treated before presented with a macula involving TRD. We can see a small break nasal to the disc and extensive fibrous proliferation. So how do we have to manage this case? And also the recent sugar control of the patient, recent diabetic status of the patient is not known. So for such cases, it is ideal to get the physician fitness first and then plan for anti-VEGF followed by surgery. This case presented with recurrent vitreous cavity hemorrhage. Sorry for the short forms. Uh, 4 months back, surgery was done, and like in such cases, we have options to either observe them and wait for spontaneous clearance of the hemorrhage, or we can inject anti-VEGF alone, or they can be combined with surgeries and cryo. Since this in this particular case the surgery had been done more than 4 months back, anti-VEGF was injected. This is a case of tractional retinal detachment involving the macula. Here, in the fundus picture, we can see that there is more of fibrous component, not much of vascular component. In such cases, they can be directly taken up for surgery without any injection. Now, we already know about the crunch phenomenon induced by anti-VEGF. Very rarely, post PRP also crunch phenomenon can occur. This is an optosy image showing superinasally, there is tractional retinal detachment, and this patient had been advised for PRP away from the prolifs. And 1 month post PRP, the patient had presented with a macular detachment. This is an intraoperative picture, though not very clear, has shown significant reduction of vascular proliferation after injection. This is another patient showing significant reduction of vascularity 2 days post anti-VEGF injection. Now, this is a case of neovascular glaucoma with vitreous hemorrhage planned for combined AGV and vitrectomy. In such case scenarios, also we can inject and then plan for surgery. Now, these two cases are tractional retinal detachment with macular hole. The first case is having fibrovascular proliferation not treated before, whereas the second case is having more of fibrous component and have already been treated with PRP. So in the second case, they can be directly taken for surgery without any injection. And the first case, we have option to either treat them with PRP to regress and wait for the regression of new vessels, and or we can use anti-VEGF with caution and then plan for surgery. So this is another case of an 82-year-old male presented with vitreous hemorrhage, and he gave history that post cataract surgery he had good vision. Ultrasound showed subretinal hemorrhage and vitreous cavity hemorrhage, and this is an old fundus photo done outside showing some hemorrhages. It was presumed to be case of a PCV related bleed, and this case had been planned for vitrectomy along with anti-VEGF injection. So to summarize, anti-VEGF reduces the vascularity of the florid fibrovascular proliferations, which helps in easier dissection of such proliferations, and it reduces the intraoperative and postoperative complications. But precautions should be taken since there is chance of progressions of the tractional component. And the ideal time to operate would be 3 to 10 days post injection. So it is important to get physician fitness before injection. The main aim in case of proliferative retinopathies is to shorten the duration of anti-VEGF drugs by doing early vitrectomy. Whereas in case of PCV related vitreous hemorrhage, the main aim is to prolong its duration of action in the vitreous cavity to have beneficial effect in the membranes. These are my acknowledgement. Thank you.
Yeah, so you've covered the topic well, quite extensively. So, can we have some questions for the senior resident? What do you think is one of the main reasons for use of anti-VEGF? Before the anti-VEGF era, people were still operating all these kind of cases also. Can you have the, in other words, what were the techniques used earlier and what were the shortcomings of those techniques?
Intraocular bleeding decreases post-injection due to decrease in vascularity.
Yeah. Now that's what the advantage of anti-VEGF. But what were the techniques? Anyone has an idea of what were the techniques that were done before and what were the shortcomings of that? Suppose that the patient is not is contraindicated for an anti-VEGF because of a recent heart condition or thing, but still you need a surgery. Would you take the risk of an anti-VEGF injection, or
Sub PRP can be done to the available retina, which is attached to the extent possible before taking such a patient.
okay? So what was being done before the era of anti-VEGFs was intraoperative manipulations, like trying to raise the bottle height to get the intraocular pressure higher than the intravascular pressure so that you reduce the bleeding, or keep on doing cautery at the bleeder points. So what is the drawback of doing multiple cauteries?
So breaks can occur at the sites of
Yeah,
multiple cauteries.
especially with flat polyps, bleeders from the retinal surface, you are actually causing necrosis of the retina and sometimes even shrinkage of the retina. So when you actually settle the retina later, these all can open up as breaks. You raise the bottle height for too long, you'll end up getting corneal edema, which compromises your surgery. The other thing is repeated bleeding also forms a separate layer on the retina. And if you leave it unattended, it actually forms a clot kind of a second membrane. And it's very difficult to remove these, especially if you have a detached retina. Every time you try to remove it, there is always a risk of catching the retina along with this and creating breaks there. So the anti-VEGFs did revolutionize the surgical interventions for proliferative diabetic retinopathy. Why is the need to understand whether the membrane is more vascular or more fibrotic? How does it help?
So if it's more fibrotic and we are injecting, we can the TRD can get converted into a combined retinal detachment, which makes your dissection of the membranes a lot more difficult with the retinas detached. So that is one of the reasons we need to look at the fibrous component of the FEP.
Yeah. So in theory, this not really doesn't really cause a regression of the new vessels. It more causes a vasoconstriction kind of thing. So the vascularity does go down, and like what you said, this is basically an interplay between the VEGF and the connective tissue growth factors. Because the VEGF levels have gone down, the connective tissue still continues to act, and that's why the fibrotic element still progresses. And we try to use that advantage of a fibrotic process being initiated uninterrupted in that window period of 3 to 5 days or 7 days, so that the tissue planes are much more delineated. Because the biggest difficulty in a diabetic patient is with young diabetics. So can someone tell why young diabetics are difficult case to operate?
Sir, and
Now, what's the peculiarity of a tractional detachment in a young diabetic as opposed to a elderly diabetic?
The PVD induction will be difficult in case of young patient, and the vascular component are much more in case of young diabetic.
Correct.
The bleeding chances are more.
Yeah. So basically, 2 or 3 things you need to remember. In young patients, the prolif is much broader, it's more vascular, and there is absence of PVD. So these cases are probably one of the most ideal cases for anti-VEGF, whereas in an elderly, you may not have so much of a difficulty in doing the dissections. The window period, there is no clear-cut guideline as to what is an ideal window period after injections. There have been studies which have shown that the VEGF level drops within 24 hours. So anything after 24 hours is a good enough time to go ahead and operate. But as she has said, any delays beyond 2 weeks, there is a high chance of progression, and the risk goes as high as 5 to 18% of either developing a new TRD or a progression of TRD, and very rarely even conversion of a tractional detachment into a combined detachment because of the progression of proliferation. So, would you have some comments?
Yeah, vascularity also increases, so you can increase the risk of intra bleeding if it delays. Giving injection as a end of the surgery, what we need, yes, theoretically it's a good idea, but also what we need to understand is to healing to occur, you need VEGF. And if you put anti-VEGF in a vitreous cavity, particularly you have already dissected the membranes, cut through those vessels. Even in fact, the closure of the vessel also get delayed. And in fact, there are reports suggesting the increased amount of like a vitreous hemorrhage in a post-operative period where you give anti-VEGFs. And that's why it is controversial. Both we have some papers supporting both the sides. So as a routine, we do not give at the end of the injection. Yes, there are few surgeons, what you rightly mentioned, as a routinely they inject end of the surgery before closing. I think otherwise you have covered most of the thing. I think very well covered, quite extensive topic otherwise.
Sometimes I feel that anti-VEGF is a double-edged sword. The cases that we are given, I don't know why, but I've seen in my patients after giving anti-VEGF, those cases, those who need anti-VEGF before surgery obviously are really, really sick retina because they have, you clearly explained, one with a very large polyp extending from the disc to the periphery. It obviously means that ischemia is so much that such a large membrane is allowed to grow, and there are so many multiple points of attachment of such a polyp that we don't know which is one major supplier, because these are all basically, they're not capillary anymore. They're actually new vessels which appear like capillary, but they do have one large or two or three large trunks which will actually bleed and it will not disappear with your anti-VEGF. Only the finer trunks will go away and allow it to shrink. The larger trunks will remain. So they do have a possibility of bleeding also post-operatively. The problem is that such sick eyes, I have seen in cases where I have given anti-VEGF and done surgery. I do find the nerve is unhealthy, even though surgery was fast. Ultimately, we're trying to do a fast surgery with easier dissection plane and everything. You end up with a very pale disc, flat, almost featureless retina. Some vision the patient has, but I don't know what I have achieved finally. What in the previous era when they were doing surgeries without this higher small gauge vitrectomies, and they were using scissors a lot. Somehow, even I feel still believe cutters are great. They do fantastic job of very fast dissection, but the scissors probably were doing a good job of crushing and reducing the bleeding when you start doing the membrane dissection. So they kind of help in controlling bleeding. When you use the scissors, not the scissors that we use now, they're too fine. We were using those vertical and those horizontal scissors. They had slightly big blades, 20 gauge, and they really, see, scissor action is usually, it's a shearing force and then it cuts once you break the shearing stress of the tissue. So they really shear first and then they cut. So it's like that. So those scissors were really lovely. We have seen in that era when we were using 20 gauge VF as fellows. The bleeding used to be there, but the kind of dissection that happens with 20 gauge and the kind of bleeding that we see nowadays is really different. Small gauge, somehow we are doing fast because the cutters are great. There is good support. Intraocular pressure is just when you step, it goes up to 60 immediately. You have so much control. But at the end of the surgery, I find that everything done well. For cases that are so sick, they do not end up with a really great visual outcome. It look great post-operatively photographs. But I'm not sure. The nerve is almost dead. This is my experience, sir, with a really sick case.
Are you blaming the anti-VEGF for the disc pallor?
It's because of the sick
that I seek, I don't think your surgery, change of technique or old technique or new technique has anything to do with the disc paddle. Anything?
Say that when we look at all we achieve is ease of surgery with anti-VEGF.
No, but see, we can't blame anti-VEGF for the disc paddle. That's what I'm trying to say. So it makes it easier. It actually enables you to manage cases which you had difficulty in the past. I remember that 30 years back when we were operating, a bunch of cases we had to abandon because the bleeding didn't permit us to complete the dissection. Then we had to take them up again after another 10 days, hoping that the involution takes place and allows us to complete. Well, these days, such abandoning is almost nil. Most of the cases you're able to complete. So anti-VEGF is definitely a boon if you're operating on very bad diabetics. It enables you to dissect pretty well. And again, I mean, it is just again my individual opinion that I don't think 20 gauge is the best instrument to do diabetic vitrectomies. Yeah, that's what I'm saying. Because why I choose even for bad diabetes 25 gauge, not even 23 gauge, is because being the small blades, the chances of creating a retinal break is very less, but you can dissect beautifully. So I deliberately choose 25 gauge for diabetic vitrectomies rather than 23 gauge. And you doing a bimanual surgery with a chandelier, 25 gauge scissors is much, much better. So I don't think a large bladed 20 gauge scissors has any advantage over 25 gauge in terms of increased bleeding or reduced bleeding. I think bleeding is more because of the nature of the eye. And if you ask me, very bad cases, put them under GA, they bleed very little. But here, of course, we have a problem because we don't have the support system of a good ICU, general people to support the patient with systemic issues. So we tend to operate under local anesthesia, which is perfectly fine. But under local anesthesia, you should understand when the surgery is prolonged, the patients become uncomfortable, their BP keeps going up, then they keep oozing, and it becomes a problem. So very bad TRDs, if you put them under GA, there's consistent control of BP throughout surgery, you can actually do surgery much faster.
Previously, in the olden days, we had one very good instrument. It was a combination instrument called aspiration cautery, which was really very good because you could aspirate the blood and cauterize it immediately. So now with this small gauge vitrectomy instruments, we don't have the aspiration cautery, and many times by the time you change from your aspiration to cautery, there is again collection of blood. But I believe recently Alcon has introduced one aspiration cautery in 23 gauge also. So hopefully that should be a little bit
I think if
easier.
you use a chandelier, you can use aspiration and cautery at the same
Yeah,
time.
if you use chandelier, yes. So now with chandelier, wide field viewing system, the surgeries become much easier. But definitely Avastin or the anti-VEGF is really a boon because without that it would be very, very tough to do these cases. So anti-VEGF, what it does, it reduces the vascularity of the membrane and then it makes the dissection a little bit easier because the bleeding is less. However, the adhesions of the membranes are not reduced by using anti-VEGF and you still have to cut all the, dissect all the adhesions. And in young versus old, what Dr. Girish was asking, in young patients, the vitreous is very solid and gel-like. So it is more difficult to remove. Whereas in old patients, you would have noticed that most of the vitreous is gone and you just have one thin membrane, which is the PHF, which is attached to the fibrovascular polyp. And once you cut that membrane, you have done with your vitrectomy, then you have to remove the fibrovascular polyp. And one more thing is while you are using the anti-VEGF injection on one side to reduce the vascularity, please check whether these patients are using any anticoagulants because most of these patients have very bad cardiac situation and most of them would be using anticoagulants. So the anticoagulant also needs to be stopped before you undertake such bad cases for surgery because otherwise the bleeding will not stop even if you have used anti-VEGF. So even if one small snip somewhere, you will have a lot of bleeding. And there was one photo which you showed, Debarati, in one of your slides. I just wanted to make one comment on that. You had two fundus photos of PDR before laser and after laser.
While she gets that, I also want to say that the valve cannula system has also revolutionized the surgeries because previously, by the time we, with the 20 gauge, we come out with and go with the next instrument, the IOP would have lost and the bleed would have increased. Whereas here, if you keep a pressure at 40, even if you take out the instrument, and if it's a new valve cannula, the pressure remains at 40, and if the bleeder is not bleeding, it would stay closed that way.
If I can add a point, um, and though Debarati has covered it very well, that new vascularization is one of the indications. For me, when I do a pre-op assessment and I see that there is no PVD, that is the time when I definitely would want to inject an anti-VEGF, because I think the retinal edema which is present and separation of vitreous from an edematous retina, that is sometimes causing a lot of breaks. So use of anti-VEGF reduces this retinal edema also. So a somewhat burnt out or seemingly burnt out retinopathy, but if there is no PVD when you are picking up the patient, I would still want to inject an anti-VEGF and then take up the patient for surgery.
There was also discussion about that conclusion in anti-VEGF. One case, one indication where I would definitely use is somebody with significant diabetic macular edema. After you do vitrectomy and give anti-VEGF, it will have a very beneficial effect. But for reducing the risk of recurrent hemorrhage, may or may not, but for macular edema, definitely I will use. I was using only, I was trying to avoid using Ozurdex in vitrectomized eyes, where there are at least a bunch of cases where there were problems when you do a good thorough vitrectomy and then put in Ozurdex. It keeps bouncing in the eye like a foreign body. Patients, when they lie down, it comes on the macula. The patients were very bitter about it. And in a few cases where there was zonular problem, the actually Ozurdex migrated into the AC. It has to be removed because it was causing endothelial damage. So in vitrectomized eyes, I prefer not to use Ozurdex. I like to use anti-VEGF.
There were two fundus photos of the PDR. You said one patient had laser, and so the anti-VEGF need not be given, and another patient did not have laser. This one, yeah. So the first photo which you are showing, young diabetic TRD with macular hole, and other eye with NVG. Okay. So if you are operating for a macular hole, it's a different thing. But if the macular hole was not there, then I would not operate this patient, because here the macula is not involved in the TRD. So in this situation, maybe best would be to do a PRP first and stabilize the disease. And if at all the TRD progresses to involve macula, then I would intervene at that time, but not at a time where the macula is not directly involved in the TRD.
Okay.
I think you were talking with the presentation. You said the picture to the left you would use anti-VEGF. Is that right? Is that what you said?
Two options, either PRP or anti-VEGF.
Anti-VEGF as solo treatment or as a preoperative measure?
Preoperative measure.
Okay. So this OCT is of the macula, is it?
Yes, sir.
Probably this is one situation where one would be a little hesitant to use anti-VEGF preoperatively, because there's already fibrosis and there is a stretch on the fovea. And stretch macular holes in diabetic retinopathy are well known. And I think it's a lamellar macular hole right now. It will probably become full thickness if one was to cause contraction. So this situation, I would be a little conservative about anti-VEGF.
Anybody has any questions?
There's one more point that I've seen with DAD, ma'am, giving intracameral anti-VEGF, especially in patients with NVG, with NVI, NVA before trabeculectomy, which can help regress the NVI and then take up for surgery. That is one point.
Yeah. So if there is patient has NVG, NVI, plus minus fundus problem, definitely an intracameral anti-VEGF will help. So it reduces the NVI and the angle neovascularization very rapidly, and it will help you to control the pressure much better than just giving the anti-VEGF in the intravitreal cavity. And also in the NVG, initially when there is the media is very opaque, the cornea is edematous, you won't be able to see any fundus at all. So in that situation, you do not know what is the situation inside. Maybe it would be better to give intracamerally first, allow the pressure to get under control, and then look at the fundus and do the rest of the treatment.
The only object I have for that argument, the source of VEGF is not in the anterior chamber. It is in the posterior segment. It is coming across the zonules into the anterior chamber, causing NVI, causing NV in the angle. So unless you attack the posterior segment with your anti-VEGF, it will continue to come. So there's a transient reduction, but again, it can come back. So I would prefer giving both, if at all. If you want to have added effect on the antechamber, fine, but give intravitreal as well, and then you give in the antechamber.
Probably only indication I would say giving anti-Shinger, because suppose you can't see posterior segment properly, you are planning cataract surgery also, early cataract, and then subsequent evaluation also you want to have posterior segment, because glaucoma and anti-segment combined cataract, and you don't have time because pressure is high, probably you anticipate going to, I mean, if you delay giving in a vitreous cavity, so add partly on anterior chamber, also finish your cataract surgery, but yes, you are giving in posterior segment also. And then subsequently, once media is clear, if you add on PRP and all those things become much easier rather than wait for a long period of time.
But I think in the presentation about NVG, you said it is an option. I don't think it's any more option. It is the first treatment of choice, along with PRP, but given unless it is contraindicated.
I think just as a conclusion, the choice of anti-VEGF would actually depend on the patient's paying capacity. Otherwise, whether it's Avastin or ranibizumab or aflibercept is the same. And studies have shown that doubling the dose doesn't give an added effect. But sticking to the conventional dose is good enough for such patients.
For the recurrent vitreous hemorrhage, should we reduce the dose to the half since it's in vitrectomized eye?
No, in fact, because it's a vitrectomized eye, its clearance will be much faster. So I don't think you do. Probably the only reason for you to reduce would be if you are also using a tamponade.
At the
By the
end of
same
the-
logic as when we reduce the dose of the intravitreal drug, probably you can reduce that anti-VEGF if it's an oil-filled eye and you want to give. Otherwise,
Anti-VEGF, that should not be a treatment. Evaluate cause for possible causes for recurrent vitreous hemorrhages.
The post-vitrectomized eye?
Yeah, post-vitrectomy, whether you are looking for a sclerotomy-related proliferation, anterior proliferation, whether you have associated rubiosis, everything you have to evaluate and then check whether during surgery, look at the surgery notes, whether vitrectomy was done adequately, laser, how adequate it was. Look at the photo drawing, post-surgery drawing, whether extensive laser was there or not, whether R could not do, because sometimes what happens if you have a localized TRD, you could not add laser on the table, and then subsequently you forget. Okay. So a lot of skip areas are left. You have, suppose ARC was done or not, because all those factors, and they will help you to make a decision. And of course, ultrasonography, we are going to look at it, or UBM if necessary, rather delayed onset or recurrent vitreous hemorrhage, when you call it, you differentiate between persistent and recurrent. I mean, if it is recurrent, in general, I would prefer to have UBM done to look for a sclerotomy-related proliferation and anterior proliferation before taking any decision, whether to just inject or do lavage or whatever surgical plan you want to do, or just wait and watch.
Is there a role for intracameral anti-VEGF if there is hemorrhagic CDs which are large in a PCV case? Maybe reaching the vitreous cavity with the injection per se may not be possible.
If at all you want to treat a posterior segment disease, you inject the posterior segment. Why do you want to inject the anti-segment?
Access to the vitreous cavity.
No, your doubt is there because of large hemorrhagic CDs. You might not have space inside the vitreous cavity to put the needle and inject. So that is there. But in this situation, it's a very difficult thing to manage because obviously intracameral may not help much. You probably will have to wait for some time for the hemorrhagic CDs to settle down and then plan your management. Either if you want, you can do drainage and vitrectomy, etc., or you can just give anti-VEGF.
I think we need to decide what is your priority there. The amount of blood dictates what is your priority. Priority is to treat the blood first or the cause of the bleeding. So if the priority is the blood because it's involved in the macula, then you need to first see whether you can do a Wilson's procedure, or if it's a huge hemorrhage, sometimes you may not be able to do anything. But if you're able to do something, then it becomes a heroic procedure, do a large retinotomy, remove the blood clot and all that. Then the stress is more on managing the clot, not so much anti-VEGF. Anti-VEGF is secondary there. In some of those cases, the polyps may actually would have closed down also. So anti-VEGF comes much later. But if it is some amount of hemorrhage, but it doesn't require major surgical procedure, then you try to treat both. you can inject gas, TPA, and anti-VEGF at the same time, and try to manage the condition as in a holistic approach. So the question is of individual case. I don't think there's one question, one answer that fits all. Nothing like hemorrhage means you have to give in the antechamber. No, antechamber, as I said, it doesn't penetrate into the vitreous cavity. It's going to get washed off through the angle.
Basically, what I would like to add here, anti-VEGF is not going to help you to clear hemorrhage. It is not to treat the hemorrhage, whether it's wherever it is, subretinal, pre-retinal, vitreous cavity. Anti-VEGF is mainly to minimize the risk of further bleeding, which acts on those active bleeders and all those things. And if there's no further bleeding, probably existing blood will clear much faster, which otherwise not. So if vitreous hemorrhage, so treatment is not anti-VEGF. That's why you need to look for a source of it. Okay, so if you have massive blood, anti-VEGF is not going to work on that blood. What will it work on? Your polyp only, or your PCV, or that's only. Well, may not be. Basically, if a polyp is very, very florid and you anticipate a lot of bleeding and you are going to take care of taking for a surgery immediately within, as I said, we have just discussed within 3-4 days, 5 days, probably not. But generally, combined RD just happen when in a phase of when the cicatricial phase, when the polyps are contracting and then causing tug. And that is the time it just tears the retina most of the time. But if you are not doing anything and just injecting, definitely I won't in.
Yes, sir.
I think if you have no other questions, thank you for your presence.